All right. Good afternoon and welcome to this webinar titled Droplet versus Airborne Transmission of SARS-CoV-2, the virus that causes COVID-19. And Dr. Sundeep Salvi will give us an updated guideline on mask use in the light of evidence coming out on airborne transmission. Now, how the coronavirus travels through air remains one of the most divisive debates in the COVID-19 pandemic. And then recently, as we had seen, more than 200 scientists, or to be exact, 239 scientists wrote to the WHO stating that transmission via airborne micro droplets is an important pathway. They urged WHO to seriously consider airborne transmission of the coronavirus and to look into guidelines or new guidelines taking into account the airborne transmission of the virus. So what does this mean for the use of face masks? This webinar, hopefully with Dr. Sundeep Salvi, will help answer these very important questions. Before I pass on the floor to my colleague, Dr. Jaya Shreedhar of Internews, there are a couple of house rules here. Firstly, please mute all your mics. We don't want any background noise interfering with the webinar. And if you want to leave your video on, you can. If you don't want to, it's up to you. It's just to let you know that this webinar is being recorded and it will be put on our Facebook Internews COVID-19 Facebook page, yeah? And also I'm trying to get it on Facebook Live. So right now, I'll pass the floor over to my colleague, Dr. Jaya Shreedhar. Dr. Jaya, on to you. Thank you.
Thanks, Sunny, for that, for setting the context. And I'd just like to add a little bit more to it. So it looks like, again, WHO is caught in the eye of a most unavoidable and unfortunate storm, being sort of the leading institution that has to issue guidelines and, sort of, guide the world through what we do in this sort of a crisis. There's always this crunch between where do you go with your guidelines when there's just not enough time to go through those systematic reviews and come to, apply your grade and come out with a proper, guideline that takes time. And it's just not enough to go on a bunch of studies that all seem to point in the same direction. WHO has protocol development and, the guideline development procedures that are stricter than strict. And every one of their recommendations translates into millions of dollars on the ground. So, WHO finding themselves in a jam again. So should they be speeding up their review process, or how much credibility should they be, how much weightage should they give to, this study published by the two aerosol scientists and supported by over 200 other scientists? These are some of the questions that we will sort of explore as we go forward through this. Dr. Salvi, we're really pleased to welcome you to this debate. And I think the timing couldn't be better. And we would really appreciate clarity from you on two major sets of areas. One is this droplet versus aerosolized transmission. If you could break that down for us, and what are the implications of these two modes of transmission for community settings, healthcare settings, and what about in the open, And the second part of the presentation, if you could sort of look at the role of masks in preventing transmission. What kinds of masks, how often should we wear them, what way should we wear them, and are they washable, and so on and so forth, and all this plethora of masks that are available in the market. It's become quite a booming market now. So if you could answer some of those questions and sort of, leave the floor open for questions afterward, we would be grateful. But before, I ask you to sort of go ahead and dive into your subject, let me say a few words of introduction. about Dr. Salvi, the rest of the group. He is the director of the Pulmocare Research and Education Foundation in Pune. Before that, he headed up one of India's premier research institutions on respiratory diseases. It was known as the Chest Research Foundation of India, also based in Pune. And together with his team, they have published several papers and won several awards for their work on respiratory diseases. Dr. Salvi personally, he's published over 225 research papers on respiratory diseases, and he's the only Asian member of the GOLD committee, which looks at chronic obstructive pulmonary diseases. And he's an award-winning scientist and also been generating a lot of debate recently with his publications and his talks on the role of masks in preventing the spread of SARS-CoV-2. So with those few words, Dr. Salvi, may I invite you to sort of start off with your presentation, and let's get better clarity on this whole debate. Thank you so much.
Thank you so much, Dr. Jaya, for those very kind words. It is indeed an honor and a privilege for me to share this this platform with so many elite people sitting here in the audience. Thank you so much for giving me this opportunity. Just give me a minute before I... Can you see the slides?
Yes, Doctor.
Yes.
Okay. So wish you all a very good afternoon and welcome to this afternoon webinar on how the SARS-CoV-2 virus spreads in the community, what is the difference between a droplet and an aerosol, and what impact will this knowledge have on public health measures for both prevention as well as treatment. And then this will be followed by an equally important topic on the role of masks. I can assure you that we believe that we know a lot about masks, but even the medical community, sadly, know very little about masks. And I thought it is important to share that knowledge over here as well. I bring to you greetings from my institute called the Pulmocare Research and Education Foundation, situated in the city of Pune. And if anybody of you all happen to come to Pune for any reason, do come and visit us. It will be a pleasure to show you around and share with you all the interesting research that we're doing here in the field of lung diseases. The COVID-19 pandemic has taken the world by storm. An estimated 14.5 million people are affected or infected by the virus. And this has also led to more than 606,000 deaths across the world. The word COVID actually is derived from three words. The first two letters, CO, they originate from the word corona. So this is a coronavirus. This is the seventh in the family of the coronavirus that we know so far. There have been 6 other coronaviruses in the past, and 2 of these, the MERS-CoV and the SARS-CoV, are the ones that we perhaps are a little more familiar with. These are the ones that caused the SARS epidemic a few years ago, and the Middle Eastern respiratory syndrome epidemic, especially in Saudi Arabia and in Korea. The remaining coronaviruses generally have caused only mild upper respiratory tract infections, just like a typical flu. Therefore, they have not been of much clinical relevance. A particular coronavirus called SARS-CoV-2 can I request all the delegates to put their mic on mute so that none of us are disturbed. Okay, thank you. So this 7th coronavirus called as the SARS-CoV-2 is a very unique virus that started in the city of Wuhan in China in the month of December 2019. So the second 2 letters, VI, stand for the virus, and the disease that is caused by this new virus is represented by the letter D, and the letter 19 represents the year in which this coronavirus was identified. India is particularly facing a big storm in terms of the COVID-19. Even today, I hear that 40,000 cases have been reported in the last 24 hours. So the disease is spreading very rapidly, especially in this part of the world. It has been doing that in the western parts of the world as well. But I think in countries like the UK and Spain and Italy, it seems to have quietened, but not in this part of the world. The SARS-CoV-2 virus is a very good-looking virus. If you look at the picture, it's very attractive, but it's an extremely small virus. Measures between 60 to 120 nanometers. What does 60 to 120 nanometers mean in terms of the scale? So you can see to the right over here, I have taken human hair. I have cut it cross-sectionally. So the diameter of this cross-sectional hair is about 50 microns. 1 millimeter is equal to 1,000 microns. So that will give you the scale of the diameter of the hair. Now, on the surface of this diameter of the hair, 2,000 such coronaviruses could easily sit. That is the size of the coronavirus, which is important for us to know that. And the last cartoon over here is a cell that is infected with the coronavirus. The blue colors represent the coronavirus, which is sitting on the surface of the cell. There are many such viruses, and it is actually infecting the cell by going inside and then using the machinery of the cell to replicate. So it's important to have this basic knowledge about the SARS-CoV-2 virus. The virus on its own cannot survive anywhere outside. It can survive only inside a living tissue. And in the humans, we know that the SARS-CoV-2 can reside only in certain organs. And I'm going to come to that subsequently. It cannot enter into the cell on its own. It needs a receptor. So the SARS-CoV-2 will sit on a receptor, which is present on the surface of the cell. And that specific receptor will then bring the virus inside into the inner part of the cell called as the cytoplasm, from where it can start its infectious process. So the receptor is a very important part of the infectious process, because cells that only express these receptors are the ones that can get affected or infected by the SARS-CoV-2 virus. And the name of this receptor is called as the angiotensin converting enzyme receptor 2, a very, very specific receptor present on certain cells in the human body. If you look at the presence of these angiotensin converting enzyme receptor 2, it is present widely in the oral cavity. So the yellow dots over here are the places where the ACE2 receptor is expressed. But what is very interesting, and this is a very recent report that suggests that even the tongue has a lot of these ACE2 receptors where the coronavirus can infect. So it is perhaps believed that the loss of taste sensation that you get because of the coronavirus is because of the infection of the tongue epithelial cells by the coronavirus. So apart from the oral cavity and the tongue, which have very high expression levels of the ACE2 receptor, this receptor is also present in the nasal cavity, in the pharynx or the posterior wall of the nose, in the throat, and then in the deeper portions of the lung, the cells that we call as the alveoli, or the portion of the lung from where oxygen enters inside the lung. So these are the structures or the cells that can get infected by the coronavirus. Until recently, we thought that these were the only tissues that can get infected by the virus. But there has been a very interesting paper published just a couple of weeks ago that talks about the other organs where the receptor is present, and therefore you can get an infection of those organs as well. So for example, you have the central nervous system. There are these ACE2 receptors in the brain, and therefore the SARS-CoV-2 virus can also cause an infection in the brain. We talked about the upper airway, the throat and the nose and the oral cavity. These receptors are also present in the blood vessels. And we all know that from the recent evidence that the COVID-19 infection is associated with certain clotting disorders in the blood. And that is likely because of the cells that it infects in the blood vessels. Apart from the lungs, the liver also has got these ACE2 receptors, but we do not know how does the COVID-19 manifest over there. The eyes also have the ACE2 receptor, and this can manifest with something that looks like conjunctivitis because of this virus. There have been the reports of the receptor being expressed in the heart, the kidneys, but also in the intestine. And why is it important to know this? Because many of these SARS-CoV-19 patients, the SARS-CoV-2 patients, manifest with loose motions. And that is because the virus can also infect the intestinal epithelial cells and therefore can cause loose motions. So the COVID-19 is a disease that starts with the upper respiratory tract and the oral cavity, goes deeper into the lungs, and then from there it enters into the systemic circulation where it can cause infection of the other organs wherever the ACE2 receptors are expressed. How many viral particles are required to cause the COVID-19 infection? Nobody really knows the answer for that, but scientists have developed some rough estimates based on the previous SARS-CoV-1 viral infection that you probably require around 1,000 such viral infectious particles to cause the COVID-19 disease. It has been largely believed for a long time now that most of the viral infections spread from one person to the other because of coughing and sneezing. Now, when you cough, you release a large number of these tiny particles that come from your mouth called as the droplets. These droplets are made up of different sizes, and I'm going to come to that in the next slide. But there are a large number of these droplets that are released. So, for example, with a single cough, you may release anywhere around 3,000 such droplets into the air, and they come out at the speed of around 50 kilometers per hour. On the other hand, if you sneeze, you can also release these droplets into the air from the upper respiratory tract. And because the sneezing is a much more powerful effort than coughing, the speed with which the droplets come out is around 200 kilometers per hour. And each sneeze can produce around 30,000 such droplets. Now, what are droplets? Droplets are bags of water-containing substances which carry the viruses inside that. So here is a picture of that. I mean, it's a bag that contains liquid. Usually it's the water that is present in the respiratory tract. And then you can see the virus particles, the viruses, many of them in thousands and millions inside each one of these droplets. The person who is infected with the COVID-19 disease, on an average, can release about 200 million such virus-containing particles per cough or per sneeze. So, I mean, you can release a large number of these viruses because of coughing and sneezing. Now, imagine that this person has caught the infection and is now releasing the virus inside the air in the form of these droplets. Now, this person who is next to him, because the droplets are going to be floating in the air for some time, it is likely that some of these droplets may enter through the breathing, through the nose, or even through the mouth. And once the virus part of the viruses enter inside the nose or the mouth, the moment they get hold of a human tissue that contains the ACE2 receptor, it will latch onto it and then get inside the cell to multiply and then cause more infection. So this is how the virus actually spreads from one person to the other. Now, we all know that these droplets, some of them can be quite heavy. They settle down because of gravity. They can fall on, say, for example, I'm speaking while I'm sitting on a table. So they can fall on a table, they can fall on my laptop. There's a phone that is next to me, so that those droplets can fall on my mobile handset. It can fall on the books that are over here. And then if some of my friends or colleagues come and they just lift my phone because they wanted to make a call, their hand is going to get infected with the SARS-CoV-2 virus. And then some people have the habit of doing this, sitting like this, putting the finger in the mouth. All this is then going to transmit the virus from the hand to the oral cavity or to the nose or even to the eyes if you rub your eyes all the time. So this is what we believe is the route of transmission from the infected person to the other person who is not infected. Now, two very important slides, because this is going to bring out a lot of clarity in what is this whole concept of a droplet. The size of a droplet is absolutely crucial, and I'll tell you why. Any particle which is more than 10 microns in diameter is, for all practical purposes, called a droplet. So imagine a very tiny particle which is just more than 10 microns in diameter. Why is it important to know this particular size? Because these size particles can remain suspended in the air for about 1 to 3 minutes. Anything more than 10 microns, so they're 20 microns, 50 microns, 100 micron particles, they're heavy and therefore they settle down much faster. Not only do they settle down much faster, but they do not have enough lightness to travel with the wind across in various directions. So generally, the distance that these droplets travel is around 1 to 2 meters, not more than that. So any particle which is more than 10 microns in diameter will not travel a distance of generally more than 2 meters. This size particle is called as a droplet. If the particle is less than 10 microns, much smaller in size, then it is called as an aerosol. And it is specifically called as an aerosol because it remains suspended in the air for a longer period of time than the droplet. So this is a much tinier particle. And because of the light weight, it floats around for a longer period of time. And not only that, but with the wind, it can travel around around a long distance of several tens of meters. So that is a basic difference between a droplet and an aerosol. Both of them travel through air, but they have different properties in terms of remaining suspended in the air for a period of time and the distance that they travel. When the SARS-CoV-2 epidemic started, the WHO released a document saying that the spread of the viral infection occurs through the droplet route, not through the aerosol route. And therefore, people were led to believe that these are larger size particles. They don't travel a distance of more than 2 meters, and they settle down very rapidly once a person has coughed. And therefore, the recommendations that the WHO gave to the whole world was a social distance that you maintain of more than 2 meters. Why more than 2 meters? Because that's the distance where these droplets, before 2 meters, these droplets can fall onto the ground and reduce the chance of infecting the other person. So it is based on this scientific background that the WHO made these recommendations of social distancing of 2 meters, 1 to 2 meters. Now, this is one of the importance of understanding the size of the droplet. Now, here is an example that actually conveys to you what I said a little more in a picture format. So those larger particles, as you can see here, which are in red, these are more than 10 microns. A person coughs or sneezes. These large size heavy particles called droplets will not cover a distance of more than 2 meters or 3 feet around that. They will fall before that. And they'll come down to the ground much faster. The blue colored particles over here are the aerosols, which are less than 10 microns in diameter. And look at the distance that they can travel. Because they're lighter in weight, they can travel a much longer distance and they can remain suspended in the air for a longer period of time. Now, it is important for us to understand that a particular virus produces what size of droplets. Now, we know that the Ebola virus is a viral infection that essentially produces large size droplets, more than 10 microns. And therefore, the social distance that you need to maintain from an Ebola infected person is not more than 2 meters. On the other hand, if you have a measles infection, measles is also an infection caused by a virus, but the only difference between the Ebola and the measles virus is the size of the particles that are coughed or released from the infected patient is much, much smaller, what we would call as aerosols. So these aerosols travel for a longer distance of time. And therefore, the social distancing that you need to maintain for measles is very difficult, because you can't have a social distance of 10 meters and 20 meters because these particles can literally travel those long distances and cause more infection. So the distance, the size of the particle actually determines the infectiousness rate of the virus. The other important crucial feature of knowing the size of the droplet is understanding whether deposition occurs in the lung. Now here I have drawn a cartoon of what I would call as the branching pattern of the airways. So this is the windpipe that goes down over here. This is what we would call as the trachea. Then the two main bronchi, and then the branches, they branch like the branches of a tree. At the end of the branch, where you normally have a leaf in a tree, you have what we call as an alveolus, or the portion of the lung through which gas exchange occurs. Now, the reason why I have drawn this particular, what I call as a bronchial tree, or a tree of the bronchi present inside the lungs, is for this particular reason. The trachea, which is the large airway, and the two main bronchi, this is the portion of the lung where particles between the size of 5 to 10 microns get deposited. Any particle which is more than 10 microns in diameter will be filtered off in the upper respiratory tract. It will not be allowed to enter inside the lower respiratory tract, which is in the lungs. So particles more than 20 microns cannot enter inside the lungs. Particles that are between 5 to 10 microns will enter inside the lungs, but only in the larger portions of the airways. Particles which are between 2 to 5 microns, they will enter into the distal portions of the lung, which we would call as medium-sized airways. And particles which are less than 1 micron, very, very tiny particles, they are the ones that will have the ability to go into the distal, the last portion of the airways, where you find the alveoli or the lung parenchyma situated at a distance of at this distance. So if you want any particle to enter inside the lung parenchyma into the alveoli is a portion where we actually catch the pneumonia infection. If it is in the large airways in the trachea, we would call that infection as tracheitis. If it is in the bronchi over here, we would call it as bronchitis. And if it is in the last portion of the lung where the alveoli are affected, we call that infection as pneumonia. So to have a pneumonia, you need to have particles which are less than 1 micron in size. So those are the two important reasons why you need to understand the size of the droplets. Now here is a very interesting study that actually challenged the belief that particles, that aerosol particles, or even the large size droplets are released only during coughing and sneezing. That has been known for donkey's years now, that when you cough and sneeze, you release a lot of these spray of these particles. But can you release the spray of these particles even while talking? And this is a paper that was published late last year in 2019 that talked about how talking itself can produce aerosol particles from the respiratory tract. Now, why is this important? Because if your COVID-19 patient is infected with the virus and this person talks, just like how I am talking to you now, will he release the virus into the air in the form of droplets or aerosols? This is exactly what they found in this research study. So what they asked these people to do was say A at different loudness. So for example, A, 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 keep on increasing the loudness of the same letter that I am speaking. And then you can see that as you increase the loudness, you see more number of particles coming out of your mouth. And if you look at the size of the particles, they're around 1 micron in diameter. Two important things. When you start speaking, you also release these droplets or aerosols. Now, I would now call them aerosols, not droplets, because the size of these particles are 1 micron in diameter. So when I speak, I'm releasing these aerosols. If I speak louder, the number of aerosol particles become bigger. And this is exactly what the same data is shown over here. The yellow one is when you speak quietly, the yellow dots. The red dots are when you speak a little louder, and the blue ones are when you speak very loud. What is the message from this paper? It is not only coughing and sneezing that releases these so-called aerosol droplets and the droplets and the aerosols, but even talking releases these particles of the size of an aerosol particle. Breathing also produces these aerosols. I mean, so if you breathe very quietly, you release very, very, very small numbers of these aerosol particles. But if you breathe a little heavier, when would you breathe a little heavier? When you're walking fast, when you're walking on the shopping street, when you're walking in the shopping mall, you're climbing a flight of stairs, you're walking, you're jogging. That is the time when you'll be breathing a little faster, deeper, and that's the time when you'll be producing more number of these aerosol particles. So breathing also releases these particles apart from talking. Both of them release aerosol-sized particles. This is a paper that was published by a group from two centers. One is from a university in Italy, and the other one from the University of Melbourne in Australia. Estimation of the airborne viral emission, and especially with reference to the SARS-CoV-2 virus. What they were actually able to show, now on the x-axis, you can see the size of the particles which are released, and on the y-axis is the number of the particles that are released. So what you can see over here is this big one is talking loudly. Okay, so this is unmodulated vocalization. Vocalization is talking. Now, when you talk, you produce a large number of particles, which is the y-axis. You produce a large number of particles. And what is the size of these particles? 0.8 microns, which is less than 1 micron in diameter. And as the number of particles become bigger and bigger, the total number of those particles, as the size increases, the total number of those particles become lesser and lesser. Breathing is the yellow one, and blue is the normal voice that one would use for speaking. This is for shouting. Now, what is this telling us? That if you're talking or shouting or even breathing a little heavier, you can release these SARS-CoV-2 aerosol particles into the air that can have the potential to infect other people. Another paper published just a few days ago from the Institute of Physics at the University of Amsterdam. So you can see the two colors over here. The dark blue is during coughing and the light blue is during talking. You can see the droplet diameter, the size of the droplet. So this is less than 10 microns, and this is 100 to 1000 microns in size. What is interesting is when you cough, you produce particles of two different sizes. One is less than 10 microns and one is more than 100 microns. So coughing releases both droplets as well as aerosols. The number of particles produced during talking, they produce only aerosol-sized particles. There is no light blue over here, as you can see, and the size of the particles. So in fact, you produce more number of particles, small-sized particles, while talking than even while coughing. And I think it's important to appreciate this because we never believed that a simple act like talking could also release these aerosols and have the potential to cause infection. The reason why I'm telling you this is I'm going to show you in the subsequent slides. Along with this, they were also able to show that ventilation has a big impact, a very, very big impact. So on the x-axis of the second graph over here is time. So 5 minutes, 10 minutes, 15 minutes. The green triangles over here represent those viral particles which are situated in a room with good ventilation. So if there is good ventilation inside, look at the time during the duration in which the particles can remain inside that room, for a very, very short time. Yellow circles, poor ventilation, so they remain inside the room for a longer period of time. And red diamonds is no ventilation, where they can remain suspended in the air for a longer period of time. Particles of the same size, how long are they going to remain inside that indoor environment is determined by the ventilation. So the same size particles can disappear almost immediately if there is a nice gush of wind coming from the window towards the door and has taken away all the particles. The same size particles can remain inside that same room for a longer period of time if there is no ventilation inside that room. There are two factors that determine the duration of the time in which the aerosols or the droplets will remain inside, especially the aerosols, is the ventilation pattern in that area. Now, this is a very interesting story reported in the month of May from Washington, where there's this choir practice that was happening in the Skagit County, and they were not bothered about the COVID-19. They thought COVID-19 cannot affect us. It's very important for us to go and practice our choir. The God is going to be with me, and the God is going to protect me from COVID-19. It is more for me to go and do this singing. So these group of 61 members attended this choir, the singing practice for about 2.5 hours. And obviously, the American style of singing, they don't sing, they shout and they sing. So there's a lot of loud vocalization. It was in an enclosed space. So in the month of March, I suspect it must be cold in the United States still, and therefore all the windows and the doors must be closed. Obviously, because of that, there would be poor ventilation, and they were in close contact with each other. One of these members had caught the COVID-19 infection from outside. And because that one member was also a part of this singing choir, look at the number of people that this one person infected. 33 confirmed cases, 20 probable cases, and 2 people who died because of COVID-19, only because of this one person who infected around 53 individuals out of the 61 that were present in that choir practice. So that is the impact of having this knowledge that even singing can also release these aerosol droplets. Another example from South Korea, where during the 24 days, people were also not bothered about COVID that much. 112 people were infected because they attended these fitness dance classes in 12 different sports facilities. So, people are close to each other. They are exercising. Because they're exercising, they're fast. And because they're breathing fast, they are spreading the aerosol droplets, if they are infected with the coronavirus, to other people. And this is how this spread occurred in these fitness dance classes in Korea, which was just reported just about a week ago. And because of all this fact, that the WHO had categorically stated that the spread of the infection occurs only in the droplet formation route, not in the aerosol formation route. As I said, the social distancing was limited to about 2 meters, and it was believed that you don't need to do anything more than that until all these episodes, all these new research studies were published about aerosol droplets being one of the important means of transmitting the infection from one person to the other. So a group of scientists got together, said we are concerned that the lack of recognition of the risk of airborne transmission. Airborne is aerosol route of transmission of COVID-19, and the lack of clear recommendations by the World Health Organization on the control measures against the airborne virus. So because of this concern, there were 239 scientists got together. They wrote a letter to the WHO in the form of an article or a commentary. It was written by 2 leading authors, one from the United States and one from Australia. And they actually signed these documents to the WHO to say that you have to now change your, the information that you're providing people. It is not only droplet route of transmission. It is also, perhaps more important, is the aerosol route of transmission. And that is why the COVID-19 is spreading so rapidly across the different countries of the world. So this was a very, very important document that was, just very recently it was submitted to the WHO, challenging the WHO that you need to now change your advisory to the world, that it's not aerosol droplets, but it's not only droplets, but aerosol route that is also more important for transmitting the infection. Now, if it is the aerosol route of transmission, then the public health measures are completely different than the droplet route of transmission. For the droplet, you just need a social distancing of 2 meters and wear a mask or don't wear a mask. That is what the WHO also recommended in the beginning, which I thought was a big blunder. In the beginning, the WHO said that only those people who are infected or who work in the health facilities must wear a mask. Other people should not wear a mask. And I think that was a blunder that was created by the WHO. I also believe that this is a second blunder that the WHO has created of only informing the people about the droplet route of transmission, completely ignoring the large evidence that is now evolving about the aerosol route of transmission, because this now requires a completely different set of public health measures. What are these different set of public health measures? Ventilation, ventilation, ventilation. A social distancing of 2 meters is not going to be enough. Everybody has to wear a mask. And I'm going to come through that in the subsequent part of this presentation later on. But that is why everybody has to wear a mask. Because if it's spreading through the aerosol route, I mean, whether you're 2 meters or 4 meters or 10 meters, it doesn't matter. If you're sitting in a hall where the ventilation is poor, you're sitting in a hall where one person is infected, and that person happened to give a talk in front of all these people. Imagine the risk of everybody catching an infection if none of them are wearing a mask in that room. How long can a COVID-19 patient become infected? I have got the COVID-19 infection. For how many days can I transmit that infection to the others? And this is a very, very important study published in the New England Journal of Medicine just a few weeks ago that actually tells us the duration of how long the transmission occurs. So if you are an asymptomatic person, you caught the infection, but you hardly had any symptoms, no symptoms at all, or very just barely a little bit of a cough here and there, you will transmit the virus for the next 1 to 2 weeks. And that's a long duration of time. If I had a mild to moderate disease of the COVID-19, I would be transmitting the virus for the next 3 weeks. 1 additional week had I been asymptomatic. And if I had a severe disease, a severe form of the COVID-19, then I would be transmitting this infection for more than 3 weeks, perhaps even 4 weeks, a month. That is a duration of me transmitting that infection to the others. Now, this is all being studied and shown by doing the RT-PCR, the reverse transcriptase polymerase chain reaction. This is a standard test that is used to detect SARS-CoV-2 virus. The infectivity starts at a much earlier time point. In fact, even before I start manifesting with symptoms, 2 days before I start manifesting with symptoms, I can be infectious to the other people. That is what is also important for us to appreciate. Why should you wear a mask? And I thought there is no better story in history to explain this than this very interesting story that occurred in 1903 in one of the universities of Chicago, one of the major medical universities in Chicago. You can see the doctors over, the surgeons over here operating on a patient. This is the chief surgeon, the professor of surgery. You can see the assistant surgeons. You can see the nurses standing next to them. And then there is an amphitheater, which is full of the doctors who are learning surgery from this professor. On the top, you can see the bulbs through which the light is focused on the patient on whom they're operating. look at two important things over here. None of them is wearing gloves. None of them is wearing a mask. No surgeon is wearing a mask. No surgeon is wearing gloves. Why? Because it was not known to be important to wear gloves and to wear a mask. Have you visited a cinema theater? And if you visited a cinema theater, if you look behind, that light that portrays the image on the screen, very powerful light. You can see tiny particles floating in that light. And that's because of refraction. So if you have a very powerful light, focused light, you can see tiny particles, less than 10 microns as well, or even more than 10 microns, floating in the air because of this powerful light. So there was this one student who was sitting in this operation theater. This is the amphitheater, this student over here. And this is a statement that the professor actually, a lady professor actually wrote down. I was told by a student in a large medical college in Chicago. She writes, and I'm going to tell you who that she is, that he often noticed during surgery when the light was from a certain direction, he could see from his seat in the amphitheater a continuous spray of saliva coming from the mouth of the surgeon while he talked to the class and conducted his operation. Wasn't that a brilliant observation? When the surgeon is talking, he's releasing a spray of these droplets coming out from his mouth, which is falling on the patient on whom he is operating. So this student asked, shouldn't protection of the mouth of some sort be made so as to catch the droplets of sputum to prevent the patient from catching the infection or the bacteria that may be present in the surgeon's oral cavity? A very, very important question that changed the entire history of surgery at that point of time. Now, this lady who was a professor to whom this student went and asked a question was a very famous physician, the first lady professor at the University of Harvard. And she got very inquisitive about this statement. She said, looks very possible. Let me do the research to find out. So she kept these culture plates during the surgery, removed the patient, kept a mannequin over there, and kept a culture plate and asked the surgeon, please say the same thing that you would speak to the students when you're performing the surgery. So the surgeon kept on talking about now what surgery he is doing. And on this culture plate, the spray was falling. A lot of bacteria that were present in the mouth fell along with that into the culture plate. And to cut a long story short, this was the story that actually suggested that the surgeon is transmitting infection from the oral cavity to the patient's surgical site. Antiseptic mouthwashes were of no use. Talking loudly produced more number of droplets. The distance that they can travel was about 2 to 3 feet. And every surgeon had a lot of bacteria inside the oral cavity. So this was the first time that Alice Hamilton recommended that all surgeons should protect the patient being operated by the surgeon wearing a mask. It took 25 years and an incident that happened in one of the hospitals of New York. A series of severe hemolytic streptococcal post-operative wound infections in the hospital that were occurring in almost all the patients. Whenever the surgical site was sutured, there was a lot of infection that was found. They were wondering, where is this infection coming from? They knew that the bacteria that they could isolate from the wound was streptococcus bacteria, but where is it coming from? And when they took the swab from the surgeon's mouth and the nurse's mouth, 33% of them, 1/3 of them, were actually flooding, bacteria. They were throwing all the bacteria onto the patients on whom they were operating. And it was this single episode that led to the formation of this advisory, a very strict advisory across the United States. Every surgeon must put a mask. Why must he put a mask? Not to protect himself, but to protect the patient from catching the infection. I hope now you understand why the surgeons wear a mask. It is not for themselves. It is for the patients. Now, why am I telling you this? I am telling you this because the main function of wearing a mask is to protect others from catching the infection. Now, here is a very nice cartoon. Here is a person who is infected with the COVID-19. He is coughing, or he is talking for that matter. And here is a person who is, say, more than 2 meters away. But because of these aerosol droplets, none of them are wearing a mask. So the chance of this person catching the infection, the risk is 90%. Okay, that's how high the risk is. Now imagine that this person is now wearing a mask. The person who is suffering from COVID-19 is releasing those aerosols and the droplets. The risk of this person catching the infection is 30%. Okay. Now imagine that the person who is COVID positive, he himself is wearing a mask. Now when he wears a mask, the chance of this person catching the infection, even when he is not wearing a mask, is only 5%. And if both of them wear a mask, the person who is COVID-19 positive and the person who does not have any COVID-19, if both wear a mask, the chance of this person catching the infection is 1.5% only. I hope you understand the importance of wearing a mask. All of us wear a mask with the belief that it is going to protect yourself. Yes, it will protect yourself, but that is not more important. What is more important is you are going to prevent the other person from catching the infection. So wearing a mask prevents the risk of transmission. And that's the main role of wearing a mask. The second important role of a mask, or the secondary importance, is wearing a mask to protect your own self. If the other person is wearing a mask, I'm happy because I know that I will not get the infection from that person. Okay, that is the main carry home message that I would like you to take from this slide. The Spanish flu pandemic of 1918-19 was a disaster. This big ship was sailing from New York to Southampton. The few people who had caught the Spanish flu, and during this journey of several days, many people got infected. And the captain of the ship was really worried because they were all sick people by the time they reached UK in Southampton. But at that time, the importance of mask was not known. Now, when they reached Southampton, the captain of the ship had heard about the importance of wearing a mask and so on. So what he ordered on the way back from UK to US was that everybody should wear a mask. Nobody should travel on this ship without wearing a mask. And you know what he found? Not a single person got infected. So by wearing a mask, you can prevent the transmission. This was of the Spanish flu in 1918, brought down to 0%. A very similar story, but this time of the COVID-19 in the city of Wuhan, where this person, a middle-aged man, was traveling from point A to point B. He was traveling in a big luxury bus, an AC coach, which had closed windows. And he did not know that he was infected with COVID-19. He was just talking to people on the way, perhaps maybe a little bit of one cough or one sneeze. And during that journey from point A to point B, one person was able to infect 5 other people out of the 40 people who were traveling in that bus. The same person, B, was traveling from point B to point C by a smaller minibus because it was a small village that he had to go to. What he did was, after he got down at point B, he bought a mask from the bus station. And from B to C, he wore a mask and reached point C. During that journey, he did not infect even a single person. That is the importance of wearing a mask. And this is a very recent story just published, I think 2-3 days ago, a 14-hour flight from Japan to Israel with 2 COVID-19 patients. It was a small flight, it was a small chartered plane flying from Japan to Israel. 2 patients, COVID-19, and there were several others, 11 passengers and 4 crew, so about 15 people. But all of them wore a mask, including these 2 COVID-19 patients. All of them wore a mask for that 14-hour journey in an enclosed space. And by the time they reached Israel, none of them had actually caught the COVID-19 infection. Why? Because all of them had worn a mask. So what is a surgical mask? A surgical mask is a protective layer that prevents the spread of the bacteria or the viruses coming out from the mouth, coming outwards. It is essentially made up of 3 layers. One portion is made up of the woven fabric, and you can see how the microscopic feature of a woven fabric looks like. But the 2 layers are made up of the non-woven fabric. What is non-woven fabric? The polypropylene fibers produced by extremely fine sprays of molten plastic, and then when they cool down, they actually look like this. So this is the non-woven fabric. The non-woven fabric has a greater filtration capacity than the woven fabric, and that's how a surgical mask actually prevents the transmission of the viruses from going out. Everybody must have heard about the N95 mask. And I'm going to explain to you what is this N95 mask. The NIOSH, or the National Institute of Occupational Safety and Health in the United States, they laid a reference standard for different types of masks that people should wear in occupational settings. Now, there are various occupations where a lot of pollution is produced. And at these occupations, people are expected to wear specific masks. These specific masks were represented by the number of these masks. So there were 3 varieties of masks. The masks that that are not resistant to oil. So these oily particles can go through any filter, really any filter. I mean, they're very slimy. So even those tiny particles, they can pass through all the filters. So N series of the masks, they are not resistant to oil. They allow the oily particles to pass through. The R series of masks are somewhat resistant to the oil. Some particles may pass through. Okay, and the P series of masks are the ones that are completely oil proof. P for oil proof. They do not allow any oil particles to pass through. Okay, it is purely on these oily particles which are specifically produced in specific occupations that you need to wear these kind of masks. So if you're working in an oily industry, in an industry with oily particles, you would wear a P series of masks. If you're wearing in an occupation where there are no oil particles, you would wear an N series of a mask. Now within those N, R, and P, there are 3 varieties. One is the N95. What does N95 mean? It means that it filters off 95% of the particles which are more than 0.3 microns in diameter. So if 100 particles which are more than 0.3 microns in diameter pass through it, it will allow only 4 to 5 particles to come out of the other end. It will filter off at least 95% of these particles. N99 is greater filtration, 99% efficiency. N100 is 100% efficient. Doesn't allow even a single particle to pass through. Obviously, you would think that an N100 mask is better than an N95 mask. Yes, it is. But you try an N100 mask, very difficult to wear, very difficult to breathe through it. So as you increase the efficiency of the mask from N95 to N99 to N100, it makes it more and more difficult to breathe in and breathe out. You may feel suffocated if you wear an N100 mask. Even the N95 mask makes you suffocated. But if you want efficiency, you will have to live with that. Okay? There are 3 types of N95 masks that are available in the market, and I'm sure all of you have heard about the N95 masks. Now here is a molded, non-foldable, non-valve mask. There is another mask which is the same type, but it has a valve which has got an exhalation valve in that mask, and then you have a foldable. You can fold that N95, and there's no valve in that mask. Now, if I give you an option of choosing one of these 3 masks, which one are you more likely to pick up? I'm sure you're more likely to pick up the one, isn't it? And why is that? Because it looks a little sophisticated, looks a little chic. You think maybe the middle one is more effective than the remaining 2, and therefore everybody wants to buy the valve filtered mask. Now, the problem with the valve filtered mask is it should not be used in the COVID-19 pandemic. Why is that? Because the valve mask allows you to exhale air easily outside. It was intended for occupational settings where you may have a little bit of resistance when pulling in the air. But at least when you're releasing the air out, if you have a valve, the air will go out very easily In a non-infected environment, a valve is a very useful thing. But when it comes to an infection pandemic, where you want to prevent the virus from coming out easily, then you should not be wearing a valved N95 mask. I hope you have understood this, because I see a lot of people on the television wearing the N95 mask, and I feel sad about it, because these are people who are transmitting the infection in the community only because they're wearing a valved mask. Perhaps many of them don't even know the importance of that. And sadly, the government or the ICMR have had no guidelines as to which type of mask should be worn by the common man. Again, it has got 3 different layers, all non-woven fabric. N95 has to be worn very tightly. If you really want to protect yourself, you have to wear it very tightly, and you have to pay a price for that. Look at this staff nurse from Wuhan. You know, she has to wear that tight mask for 6 hours. Look at the amount of, the skin damage it has created because of the tightness with which she wore the mask. There are a lot of fake N95 masks circulating in the market, and I'm not going to really go into the details of this because I think this is not for this audience, but please be very careful. 8 out of the 10 N95 masks that you're getting that you're seeing out in the community are likely to be fake masks. They're not the genuine N95 masks. They do not have the filtration capacity or the efficiency of a good quality mask. So please be careful about differentiating between a fake mask and a genuine mask. A single layered mask instead of the 3 layers, not good enough for COVID-19. It is only useful for, in food processing industries. The dust mask made up of, a paper pad, which is molded, not good enough, because this paper pad is only used for large size particles. The droplets that I talked about, they allow the aerosols to pass very easily through this. So the dust mask is also not an appropriate mask for people to wear during the COVID-19 pandemic. The Indian government, especially the principal scientific advisor to the Honorable Prime Minister of India, actually released a set of guidelines on the 30th of March 2020, where they encourage people to wear cloth masks. And I thought this was very interesting because, from surgical mask and the N95 mask, there were not masks that people wear. And here is an advisory that came from the government to say that you should be wearing cloth masks. Now, what is interesting is which cloth mask, any specific variety of cloth mask, nobody knew which one was important until this paper that was published about, I think, a month ago. Those of you who have not read this paper, please go through it. It's a beautiful paper that will give you enough knowledge as to what should be the quality of the cloth mask that is recommended for use in the COVID-19 pandemic. What they did in this research study was they collected all these different kind of masks, and they looked at the filtration efficacy of these masks. So the cotton mask, the silk mask, the chiffon, flannel, synthetics, and then the combination of these 2, different fabrics. And then they categorize them into less than 300 nanometers, more than 300 nanometers. Why less than 300 nanometers? That is the size of the virus particle. So anything that filters off less than 300 nanometers would also filter off the virus particle as well. More than 300 nanometers, we are not bothered about it. To cut the long story short, and I'm not going to go into the details of these figures, but very interesting results over here. So less than 300 nanometers, which is the size of the virus particle, more than 300 nanometers. Let us ignore this for the time being. An N95 mask, if worn properly, no gap means it's worn properly, the efficacy is 85%. If you do not wear it properly, loose fitting mask, then the efficacy drops to 34%. A surgical mask worn properly, not bad, 76%, as good as the N95 mask. But if you do not wear it properly, the efficacy goes down to 50%. 2 important messages. The surgical mask is as good as the N95 mask when it comes to filtering particles less than 300 nanometers. Fair enough. I mean, they're close. And if you do not wear the mask properly, it is not going to offer you any protection. But this is something that they were able to show that I thought was absolutely interesting. If you take a cotton quilt mask, look at the efficiency of that, 96%. better than an N95 mask. If you take a cotton fabric of 80 threads per inch, 80 threads per inch means very, very loose fibers, less numbers of cotton fibers. There is hardly any filtration that occurs through a poor quality cotton fabric, whether you take one layer or whether you take two layers. If you have a good quality cotton fabric, 600 threads per inch, then the efficacy is as good as a surgical mask. Whether you use one layer or whether you use two layers, as good as surgical or even an N95 mask. But look at what was found over here. The combination of the fabrics, two layers of cotton and the chiffon in the middle. Look at the efficacy of that. 97%. It is even better than the N95 mask. Cotton plus flannel, 95%. Cotton plus silk, 94%. Wow. So I think this is very important. A simple cloth mask made at home can offer you filtration efficacy better, as good or perhaps even better than the N95 mask. I think that's an important message that I want you to take from this slide. Why such superb filtration? Nobody really knows. Perhaps the chiffon and the flannel, they're the ones who have some electrical charge, and any particle less than 300 nanometers, they get attracted to the electrical charge, and therefore they're filtered off more efficiently by chiffon and flannel if it is present between the two cotton layers. And I think it's important to know that. So this is the threads per inch. As you can see here, a khadi uses 60 threads per inch. So you should not make a mask of khadi. It is not going to serve any purpose in terms of the quality of the efficacy of the mask. Whereas if you take a good quality fabric, then the efficacy is going to be far better. So here is an example of cotton masks, cloth masks, which I think is an ideal thing that the community should wear. Forget the surgical masks, forget the N95 masks. The cloth masks itself are good enough to be worn in the community to prevent the spread and to prevent the catching of the infection from one person to the other. A last couple of slides. I thought that the BBC News that was reported 2 days ago, Donald Trump vows not to order Americans to wear masks. And I thought this is absolutely ridiculous. If the head of the country is not going to, give advisories to the people that everybody should wear a mask, you can only imagine what that country is going to face in the future. It is already facing. People are least bothered about wearing masks in the United States. Why? Because the president himself doesn't believe in wearing masks. And in fact, this is the first time that he wore a mask, and you can see that he wore a wrong mask because it's a valved N95 mask. So it's absolutely ridiculous. The world is going to change. It's going to be the pre-COVID era and the post-COVID era. The masks are going to be the next future. The fashion tag. Everybody is going to wear masks of different varieties. So I think we should start preparing ourselves for the future of wearing masks, because that's going to be very, very, very important. I think I'll stop over here. I'm not sure how much time I took. I probably took longer than what I should have. But Dr. Jaya, I'm now all ready to answer any questions that they have.
Yep. Lots and lots of questions. Firstly, thank you, Dr. Salvi, for those excellent slides and a wonderful, wonderful talk that everyone could relate to. I'll just start off with, maybe Sunny and I can alternate the questions between us. What do you say, Sunny? And I'll just start with one that's on everyone's minds, I think. Are these masks, the cotton and chiffon ones and so on, are they reusable? Can you wash them and reuse them? What happens to the electrical charge? That's a common question.
Very good question. Surgical masks have to be worn only once. You cannot wear the surgical mask again. The life of a surgical mask is anywhere between 4 to 6 hours. So even in a day, if you're spending a lot of time outdoors with people in crowded areas, you have to change the mask every 4 to 6 hours. You cannot wear the same mask again. The surgical mask has to be disposed of very carefully after it is worn once. The N95 mask is also to be worn only once. It cannot be worn again. It can be worn again under exceptional circumstances, but that's only meant for doctors where the numbers of masks are very limited. The healthcare providers, there are certain ways in which you can reuse it. But by and large, even the N95 mask should be worn only once in a day. I see everybody wearing the same mask every day. I think that's absolutely ridiculous. That is not going to offer any protection at all. Cotton mask or the cloth mask is the one that is washable, and that's the beauty of that. I think the main advantage of the cloth mask is it's cheap, easily available, easy to make. You can wash it at the end of the day and reuse it the next day. What happens to the electrical charge of the chiffon and the silk? Nothing happens to the electrical charge. The electrical charges are retained because of the inherent properties of those fibers, nothing to do with washing. Washing does not wash away the electrical charge of the chiffon and the flannel fabrics.
Thank you, Dr. Jaya. I think this is a question from Dr. Arun Chintararajan. He sent this question much earlier. Is an N95 mask sufficient for use in a dental practice? That's his first question. And should a surgical mask also be worn over a N95? And his third question is, WHO claims that asymptomatic COVID cases cannot transmit the disease. Has any randomized clinical studies been done to prove this? If not, on what basis do they claim this?
Okay. So earlier, there were no studies to suggest that asymptomatic transmission occurs. But now there are at least, if I'm not mistaken, at least 3 or 4 papers that seem to convincingly suggest that asymptomatic transmission does occur in the community. So a person who has caught the virus is multiplying inside his airways, he has got no symptoms, but he will be transmitting that infection. He'll be making more people infective even during that asymptomatic phase. So I think all of those days where it was believed that asymptomatic transmission does not occur, the answer is asymptomatic transmission does occur nowadays. And I think the WHO will have to change that stance at some point of time, sooner than later, because the evidence has already been built up. Should dentists wear an N95 mask? Believe me, I think a dentist is the only person who is most susceptible to catch the infection from a patient for various reasons. Why? Very close contact with the oral cavity. Very, very close contact. You're drilling, you're spraying, you're cleaning, you're doing all sorts of activities that releases aerosol droplets even during those procedures. So it's the most risky occupation as of now. So what should you do? N95 mask, on top of that a surgical mask, a face shield, and full PPE with gloves is what a dentist should wear before they start working on the patient. Not only that, but as soon as the patient walks inside the room, he is given a glass of betadine solution, oral betadine solution, to rinse and gargle at least for about 2 to 3 minutes before he sits on the dentist chair. One, as soon as the patient is over, you will have to sterilize that entire room after the patient has got over. So it's not only the chair, but everything over there has to be sterilized with the chemical spray that we have. And if you have ultraviolet light, then that is also to be used in a dental clinic. So dentists, I think you have to be very, very careful.
Dr. Jaya, you want to take the next question? Dr. Jaya, unmute yourself. Thank you.
Yeah. No, you can go on, Sunny, because I'm not able to go to the top of the chat box.
All right. Okay. All right. The second question, Dr. Sundeep, is from Priya Selvaraj. She asks whether wearing a visor dictates a leniency in the type of mask. We as receivers will wear an N95 with a visor. The patients and staff sometimes move with visor and cloth masks or 3-ply masks, etc.
The visor is useful only if you're going to be in a close contact with a COVID-19 patient, where there's going to be suction, there's going to be some, some liquid sprays coming from the patient. It's only then that you should be wearing a visor in front of you. Other than that, I don't see any real purpose of wearing a visor. An N95 mask with glasses are more than enough for the healthcare providers.
I had a question about the Swiss mask. There's a Dr. Ramni Rao asking about what about a Swiss mask?
A Swiss mask. I do not know what a Swiss mask is.
Yeah.
Is this made in Switzerland or it's a...
I'm not sure. I haven't heard about it myself.
Okay. No, I have not heard of Swiss mask.
Yeah.
I don't know what it is.
Right. And so I'll just, there's another question from Kathmandu.
Hello, Swiss mask. Swiss mask is having some ionic properties in it. Swiss mask. Swiss mask has some ionic properties, and I don't know whether that can help in. It's supposed to be antiviral.
I see. I think we'll hear more about it. We'll look that up. But I just wanted to ask about another question from the Times of India. Can one get infected if the droplets enter the eyes? And do we have to wear protective eyeglasses along with the masks? Dr. Salvi? Yeah. Have we lost Dr. Salvi, Sunny? Sunny, have we lost Dr. Salvi?
No, where is he?
I'm looking for him. I think he's sort of dropped off and he's going to reconnect in a minute.
Okay. Can you give him a call?
Yeah.
Jaya.
Yeah.
Jaya.
Yes, tell me.
Can we get, at the end of the webinar, can we get some reasonable recommendations for what the public should be using?
Yeah,
taking the social aspects of India into consideration.
Absolutely. I was going to sort of...
Theoretically, something can be great, but practically, what can we do?
Yeah. Well, from the way the, people are rushing to the Kasimedu market and, before the lockdowns to buy the vegetables and so on, I think that it's going to be very, very difficult. Hold on, I'm just trying to reach Dr. Salvi on the phone. Maybe he has a power cut.
I think so.
Not answering the phone either. Hold on, let me try again. But if anyone has other questions, please feel free to discuss.
Hi, Jaya. Thanks. Excellent. This is Anandi Yuvraj from Coimbatore.
Anandi, how nice to see you here.
Yeah, I just got it, this information about this session, and I just immediately, got into this. Excellent for coordinating. And it was just like, people have started promoting face shields and visors and I know how good is that, because seems like, there is an economic kind of a point of view, in really coming out with new, tools and, besides masks.
Absolutely.
Yeah. How do we deal with that?
Well, that's going to happen because I just saw something going around on WhatsApp. Someone's promoting, anti-COVID shirts and then immuno bread and things like that. So I'm sure that people who sense a market potential of this whole thing are going to sort of, go ahead with that. It's very strange. I'm not getting through to Dr. Salvi either. Just let's give it a couple of minutes because there's so
hello. I'm in.
Oh, Dr. Salvi.
I'm so sorry. My lights went off. My lights went off. I'm so sorry.
Yeah,
All
there's
right.
lots of questions, Dr. Salvi.
I'm so sorry. Yeah.
No issues. It's just that about the visor. I mean, the use of the visor is being widely promoted. So that was one of the questions. And Dr. Manjula had an important question. Moving forward for countries like India or, Cambodia or Thailand or the other countries of the Asia Pacific region, what should be really the government's recommendations vis-a-vis two things? One is physical distancing, and the other one about the use of masks. How does one really promote public awareness about these things, and what are the ways to sort of enforce it? So what should be the recommendations moving forward? Also, I think there's got to be very clear recommendations for prevention of COVID-19 in healthcare settings. So that's not very clear either from the government of India. So could you sort of throw some light on that? Thanks.
Okay, I think from a scientific point of view, the evidence is very strong to do three things: social distancing, hand hygiene, and wearing a mask. I think all three are important. Out of these three, I believe the wearing the masks is the most important one, because of the new knowledge that we have gained about the aerosol route of transmission. So I think the best thing that a government could do is to create an advisory that every person should wear a mask the moment he goes outside his house. The moment he steps outside his house, he must wear a mask of a good quality. And a good quality mask obviously doesn't mean a valved N95 mask or a surgical mask that the person has been wearing for the last 10 days, or the N95 mask which the person is wearing for the last week. I think it's very important to educate the people, A, about the importance of wearing masks, B, about which masks, and who and how should they wear the masks. I think this awareness should be the first step in all the countries in this region. Countries like Korea, countries like Japan, inherently they wear a mask, whether it is COVID or whether it is no COVID. And if you look at the spread of the COVID-19 in these countries, especially in Singapore, Japan, I think the spread has been very, 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 very small. So these are the countries which were least affected because of the COVID-19. And I believe the main reason for that is the habit of wearing masks. And I think it has now to be made a culture within the country to bring about this big. It's a big cultural change. Personally myself, if you ask me, you have to wear a mask from tomorrow every day, I would say, of course, I'm not going to do it. But now I know the importance of it. So I think the information must be passed on to the public in a very sensitive manner. You have to educate them in a very innovative way about why everybody should wear a mask. I think then the things will start happening. The evidence that if most people wear a mask in the community, will it halt the spread of the COVID-19 infection? The answer is yes. There are at least two big studies. One, so these are the studies done by mathematical modelers in the United States, and they have clearly shown that just a simple thing like wearing a mask can reduce the load of COVID-19 by between 50 to 80%. I think what better thing could you ask for? If there is such an effective solution already available, now it's only a matter of implementing it into the community. And as a doctor, I do not know what it takes for implementation. The only thing that I know is you need to first create awareness. So that's very, very important. The visor is something that I answered. I think a visor is useful only when you're in an ICU setting where the patient is coughing, sneezing, and the liquid droplets are likely to be splashing onto your eyes or ears. That's the only time where you require a visor. Otherwise, I don't think a visor is necessary for all healthcare providers. What is the advisory for the healthcare providers? I think, Dr. Jaya, if you visit a hospital today in Pune, a COVID hospital, it's flooded with people. There are no beds available. There are no beds available for patients. There are tens or hundreds of patients waiting outside to come inside the hospital. How do you create a system in place in the hospital where you protect not only yourself but your colleagues and the other people working around with you? It's a challenge. Let me tell you that it's not easy. but we need to step up to that requirement and raise up to the standards. I think that's the only thing we can do.
Mr. Sunny, are you coming in with a question or?
Yes, I'm coming in with a question. This is from Surendra Puyal, formerly BBC and now a freelancer in Kathmandu. His question, Dr. Sundeep, I'm in Kathmandu, Nepal, and I'm like most of us very concerned about the rapid spread of COVID-19. What's your suggestion in one line for all South Asians?
Awareness and wearing masks should be the topmost priority, absolutely topmost priority. You know, hand hygiene is possible, feasible, only in limited circumstances. Ideally, you have to wash your hands 10 to 15 times in a day. When will you get that opportunity to do that? It's only the rich people who will be able to afford a sanitizer bottle that they can put in their pocket and then, you know, take 2 drops and then sanitize. 9 out of 10 people will not be able to afford sanitizers. Social distancing is going to be a challenge in countries like India and Nepal because of the sheer population that we have. So with limited amount of opportunities for hand sanitization and social distancing, I think masks then remain the only solution, the only major solution that will have the potential to reduce the burden. So I think wearing a mask is going to be the most crucial solution, even in a country like Nepal. But how to bring about that change? It's a social, cultural change that needs to be brought in. It has to be feasible. Cloth mask, as I spoke, is a good solution. And I think by God's grace, I think, otherwise imagine if there were no cloth masks that were shown to be effective. Only the surgical masks and the N95 masks were remaining. So that would have been practically impossible to bring about any sort of change. Now the cloth masks are offering a solution, and they're offering as good a solution as what these 2 masks are. So I think we must exploit that and bring about this transformation at a very basic cultural level.
Okay, Dr. Sundeep, I think we have one of our attendees who's put his hand up, Nagendran Moti. Do you want to ask your question right now?
I want to ask.
Hello?
Yeah.
Please go ahead.
Yeah.
Please go ahead.
This cotton and chiffon mask that doctor is very highly recommending, are they available in the market? And if so, where exactly and what specifications we should look for to buy that?
So what I shared with you are the results of a research study that was conducted in the United States.
Yeah.
It's a very prestigious laboratory where the research was conducted, and the results is what indicates that a combination of cloth and chiffon offer protection or filtration which is as good as an N95 or even better than that. I think that's the message that I am trying to convey to you. Now, how do you make those masks? Which cotton, which chiffon? I don't think I have the specific answers for that. But by and large, I think if you have a 2, 3, 4 layered mask, a cotton mask, or a 2, 3, 4 layered cotton chiffon mask, you are likely to bring about a good filtration efficacy than wearing nothing or even wearing the surgical mask.
Just have a couple of questions. One is on the role of UV light. Ultraviolet radiation kills the virus. So how does that work in a healthcare setting? And, is it better in hill stations where there's greater UV light? That was one question. And the other one is a question about in a busy OP, in a busy OP, can one remove, if you're wearing a very good cotton and chiffon mask, can you remove it between consultations? How does that work? Does that, increase your risk?
Okay, ultraviolet radiation is known to kill all viruses, including the SARS-CoV-2 virus. So wherever practical and feasible, you must put these ultraviolet lamps that are available in your clinic settings. Yes, I would recommend that. High altitude, more ultraviolet radiation maybe outside the house or the office, but inside, I think the ultraviolet radiation doesn't pass through. So you will require a different source of ultraviolet radiation inside. And the second question was with regard to when should you remove your masks? So imagine, I mean, Dr. Jaya, it's important for us to appreciate whenever a healthcare provider works in an ICU setting, whether it be a nurse or a doctor on call, they wear that PPE for 4 to 6 hours non-stop. They sweat inside. They have to wear it so tightly, so the skin is burning. It's, they can't even drink water. They can't even go to the washroom. That's the unfortunate side of it. I mean, it's not easy. So you have to live within those constraints, because the moment you remove it, have a glass of water, you have to remove everything then, and you have to change the whole PPE once you change it, you throw it again. So you have to wear a separate PPE once you've had a glass of water or a cup of tea. So those are the compromises that one needs to make in a healthcare setting like the ICU at least. Between consulting.
Yeah, this is about the OP. In an OP, when you're wearing the mask.
So as the patient has gone out, let there be nice cross ventilation inside the outpatient department. Don't see a patient for at least, say, for 2-3 minutes. You can remove it and get some fresh air, have a glass of water or a cup of tea. You can do that, certainly.
All right, I think we'll take the last question. We're running short of time. And Priya Selvaraj has raised a hand. Priya, can you?
Yes, I'm here. Can you hear me?
Yes, we can hear you.
First of all, I'll quickly compliment Dr. Salvi on the wonderful presentation. I think it covered all aspects, fantastic. And I'll be sharing this recording soon with many of our colleagues. So 2 things, quick questions. One, I'm sure you'll shoot it down, because initially when COVID came by and there was paucity of N95 masks, what they recommended us to do was to actually UV radiate it and wear it again. So we were doing that because we were conserving the masks. So that's one thing. So I don't think that's recommended anymore, right? We have to change it every 4 hours. There is no way of wearing it and re-wearing it. No.
No, ultraviolet radiation spoils the filtration capacity.
Okay, got it.
Woven fabric. So in the ultraviolet radiation should not be used.
Okay, done. Second question was, I was the one that raised about wearing visors, because we are having an OPD practice and in an OBGYN setup. So we are all wearing N95, and it's literally taped to our nose because we have to wear our glasses over that, because it'll get fog when we are breathing, and if it's not properly fitted. So we tape our noses, then we wear the visor. And why I raised the question about visors is because largely the population, 80% are asymptomatic carriers. And unless you test them, you will not know who is COVID positive or negative.
Absolutely.
So that's the reason why I thought it's very essential. If it's 4 hours of suffering, I may as well suffer with that. People have done much more greater things in the ICU. So I think maybe it would be nice for us to, spread it like we do wear visors as healthcare personnel to protect our patients, in case we are asymptomatic ourselves. I just wanted to raise that point, Dr. Salvi. And thank you so much. I've learned a lot in this lecture. Thank you so much.
Thank you, Dr. Priya. I think you're the frontline COVID warrior. So you probably have more experience than what I do. So maybe you're more right with the use of visors. So
just as a part of protocol, that's it.
I would agree to what you're doing, what you're saying.
Thank you so much.
All right, I think it's time to end right now. Thank you, Dr. Sundeep Salvi. Fantastic. I've been a real fan of you. Been following you very closely and enjoyed your lecture actually on yin and yang. Actually. That was great.
Okay.
And Dr. Jaya, thank you so much. Dr. Jaya, my colleague from Internews. And I'm Sunny Krishnan from Internews as regional regional health advisor for COVID-19. I thank all of you for coming today and attending this wonderful webinar. We learned so much, and we had a record crowd here of over 60 participants at one go. So there is a recording on the Facebook live, on the Facebook channel, and we'll be sending out the recording also on our Internews Facebook site. Thank you very much. God bless and stay safe.
Thank you.
Thank you.
Just one very last question, Sunny, and it's come up a couple of times.
Yes.
The role of goggles or eyeglasses,
Yes.
should they be worn along with the mask when we go out in a community setting or in the healthcare setting? That's the last question.
It makes good sense to do that, because a person who is infected not wearing a mask is coughing, aerosols are spreading in the air. They're likely to enter through your eyes into the respiratory tract. So, but I don't want to create that sort of a panic and say that, okay, everybody should wear glasses, everybody should wear a mask. I think so wearing a mask will protect you 95% of the times, and the glasses will be an additional 5%. So if you want to be 100%, yes, you'll have to wear a mask. You'll have to wear goggles.
Thank you so much,
Thank you.
Dr. Salvi. This has been a brilliant learning experience for all of us. We greatly appreciate it. And in the coming days, we hope to see some clear guidance from the WHO on this, and that guidance translating into governmental guidance in all the Asia Pacific countries. So we really look forward to more clarity in the days to come. But rest assured that you have sufficiently panicked all of us. So we'll take great care from now on. I think we'll start taking things much more seriously, because some level of fatigue has set in, I think. We're becoming complacent about masks and so on. But these two things about the asymptomatic transmission possibility, as well as the aerosolized transmission, I think we have to redouble our efforts to really be responsible in our own behavior to the communities, and also, in the community setting, be very, very careful about how much risk we're taking. We're very grateful for your excellent, excellent talk. Thank you so much. And Sunny, my colleague, thank you for organizing this seminar. Thank you so much.
Thank
Bye.
you. Thank
Bye.
you. Bye.